Hi everyone, a wonderful and blessed day to all. May God send His Holy Spirit to guide you as you fulfill your call to be His future healthcare warriors. May I also be used as His instrument to be your guide in your nursing journey, to help you become the best nurses in the near future, with knowledge and wisdom to know the difference between right and wrong. A nurse with a heart that cares, a hand that heals, and a words that comfort wounded heart and worried mind. So the first topic that we will discuss for this week is the physical examination of the peripheral vascular system and lymphatic system. So remember that careful assessment of the peripheral vascular system is essential for detection of peripheral arterial disease, or known as PAD. Before we proceed with our discussion, let me present to you these disclaimer slides. So the following are the learning objectives of this presentation. So at the end of this presentation, the student will be able to identify the structures and function of the arteries, veins, and lymph vessels and nodes. Perform accurate health history taking of the peripheral vascular system. Identify the locations and palpate the peripheral pulses for rate, rhythm, and amplitude. Evaluate and interpret variations in pulse, rhythm, rate, and amplitude. Discuss risk factors for peripheral artery disease, chronic venous stasis, and thromboembolic disease. And discuss risk reduction and health promotion strategies to reduce peripheral vascular disease. So let us now have a review of the anatomy and physiology of the arteries. So remember that the arteries contain three concentric layers of tissue: the intima, okay, which is also known as tunica intima, the media or the tunica media, and the adventitia, or known as the tunica externa. So the internal elastic membrane borders the intima and the media. The external elastic membrane separates the media from the adventitia. So the innermost layer of all blood vessels is the intima. It is a single continuous lining of the endothelial cells which synthesize regulators of clotting, modulate blood flow through synthesis of vasoconstrictors and vasodilators. It also regulates immune and inflammatory reactions. So the media is composed of smooth muscle cells that dilate and constrict to accommodate blood pressure and flow. So the inner and outer borders or boundaries are the membranes of elastic fibers or elastin, that is called internal and external elastic membrane, okay, or laminae. So small arterioles called the vasorum perfuse the media. Okay. The outer layer of the artery, again, is known as the adventitia, which is a connective tissue containing nerve fibers and the vasa vasorum. Okay. So another image, or this image shows atherosclerosis, no? Which is a chronic inflammatory disease initiated by injury to vascular endothelial cells that provokes atheroma or atheromatous plaque formation. So, or fatty layers. So, nakikita natin dito. This is a cross-section view of the arteries with a fatty layer deposit, no? Okay, and this is due to vascular lesions of hypertension. So, kapag sobrang dami na ng fats or cholesterol, so nagiging humaharang na itong mga fats or known as atheroma. And it is called atherosclerosis. Arteries must respond to the variations that the cardiac systole and diastole generate in cardiac output. So their anatomy and size vary according to the distance from the heart. So the aorta and its immediate branches are large, highly elastic arteries such as the pulmonary, the common carotid, and the iliac arteries. So here we have the arterial pulses that are palpable in arteries lying close to the body surface. So in the arms, note the following pulsation in the brachial artery, radial artery, and ulnar artery. So the brachial artery located at the bend of the elbow just medial to the biceps tendon, while the radial artery is on the lateral flexor surface. On the other hand, the ulnar artery is on the medial flexor surface. We have here two vascular arcs within the hand that interconnect the radial and the ulnar arteries. So the purpose of this is to protect circulation in the hand and fingers against possible arterial occlusion. So just in case occluded ang radial artery, there is still the ulnar artery that will supply blood to the fingers. Okay, so another location of our arteries. In the legs, we have to palpate pulsation in the following areas. The femoral artery, which is located just below the inguinal ligament and midway between the anterior superior iliac spine and the symphysis pubis. So this is your femoral artery. While the popliteal artery is an extension of the femoral artery that passes medially behind the femur. So palpable just behind the knee. This popliteal artery divides into two arteries perfusing the lower leg and the foot, namely the dorsalis pedis artery on the dorsum of the foot just lateral to the extensor tendon of the big toe, and the posterior tibial artery behind the medial malleus of the ankle. So it's the same with your arm. Parang merong arc, no? There is an interconnecting arc between these two arteries that branches, no, to supply blood circulation to the foot. So let us now compare the artery and the vein. So by looking at this image. So unlike arteries, the veins are thin-walled and highly distensible, with a capacity for up to 2/3 of circulating blood flow. So the venous intima consists of non-thrombogenic endothelium. Okay, so protruding to the into the lumen are the valves that promote unidirectional venous return to the heart. So you have to remember that your vein carries an oxygenated blood. Pupunta siya sa heart, circulation, and then to the lungs for gas exchange. Once na oxygenated na siya, babalik siya ulit to the body Okay, so arteries na ang magdadala. So, the arteries carries oxygenated blood. Okay, so the media contains a circumferential rings of elastic tissue and smooth muscle that change vein. So the veins from the arms, upper trunk, and head and neck drain into the superior vena cava, which empties into the right atrium. And the veins from the legs and the lower trunk drain upward into the inferior vena cava. Because of the weaker wall structure, the leg veins are susceptible to irregular dilation or varicosities or compression, ulceration, and invasion by tumors and warrant special attention. So, the veins or the deep and superficial veins in the legs are the great saphenous vein, small saphenous vein, and the communicating vein. Okay, so the superficial veins are subcutaneous with relatively poor tissue support. They are the following, or the deep and superficial veins in the legs, known as the great saphenous vein, the small saphenous vein, and the communicating vein. Okay. So, the great saphenous vein, it originates in the dorsum of the foot and then passes just anterior to the medial malleus and continue up to the medial aspect of the leg. And it joins with the femoral vein of the deep venous system just below the inguinal ligament. While the small saphenous vein, which begins at the side of the foot, it passes upward along the posterior calf and joins the deep venous system in the popliteal fossa. So, andito na siya, naka-join na siya. While the communicating veins are the veins that communicate the two different points of the venous system. Okay, they can communicate with the great saphenous vein with the small saphenous vein. Okay. Moving on to the lymphatic system. The lymphatic system is an extensive vascular network that drains lymph fluid from the body tissues and returns it to the venous circulation. So the system starts peripherally as a blind lymphatic capillaries, and it continues centrally as a thin vascular channels, then collecting ducts and empties into the major veins at the neck. So the right lymphatic tract or duct drains the fluid from the right side of the head, the neck, the thorax, and the right upper limb, and it empties into the junction of the right internal jugular vein and the subclavian vein. Okay, here. So the thoracic duct collects the lymph fluid from the rest of the body and empties into the junction of the left internal jugular and the left subclavian veins. So the lymph fluid transported through these channels is filtered through the lymph nodes that interpose along the way. The lymphatic system and the lymph nodes has vital function in our body. So first is the vascular function, and aside from that, the lymphatic system also plays an important role in the body's immune system. Okay, the cells within the lymph nodes engulf the cellular debris and bacteria, and it produces antibodies. So only the superficial nodes are accessible during physical examination. This includes the head and the cervical nodes, the clavicular nodes, the axillary nodes, and the epitrochlear nodes, also the inguinal nodes. So the axillary lymph nodes drain most of the arm. So lymphatics from the ulnar surface of the forearm and the hand, the little and the ring fingers, and the adjacent surface of the middle finger, however, drain first into the epitrochlear nodes. So these are located on the medial surface of the arm, approximately at 3 cm below the elbow. So lymphatics from the rest of the arm drain mostly into the axillary nodes, and a few may directly go to intra or infraclavicular nodes. So the lymphatics of the lower limb follow the veins, and it consists of both the deep and superficial system. Again, only the superficial nodes are palpable. So the superficial inguinal nodes include two groups. We have the horizontal and vertical group. So the horizontal group lies in the chain high in the anterior thigh just below the inguinal ligament. So it drains the superficial portions of the lower abdomen and the buttock, the external genitalia, the anal canal, and the anal area and the lower vagina. On the other hand, the vertical group lies near the upper part of the saphenous vein, and it drains a corresponding region of the legs. So the blood circulates from the arteries to the vein through the capillary bed. So here the fluids diffuse across the capillary membrane, maintaining a dynamic equilibrium between the vascular and the interstitial spaces, and most of the filtered fluid returns to the circulation not as a fluid reserve at the venous end of the capillaries, but as a lymph through the lymphatic system. So the fluid exchange and capillary bed are influenced by the following pressure: the hydrostatic pressure, the interstitial colored oncotic pressure, and the colored oncotic pressure of the plasma protein. Okay, so let us further discuss the capillary microcirculation. Okay, so the force of hydrostatic pressure means that as the blood moves along the capillary, the fluid moves out through its pores and into the interstitial space, while the oncotic pressure or the colloid osmotic pressure is a form of osmotic pressure induced by proteins, for example, the albumin in the blood vessels plasma, that causes a pull on fluid back into the capillary, while the colloid osmotic pressure or COP, which is the osmotic pressure exerted by the large molecules, serves to hold the water within the vascular space. Okay, so one findings when you are conducting your physical exam could be edema. So edema is produced by four mechanisms: due to increased plasma volume from sodium retention, could be due to increased capillary membrane permeability, related to burns, snake bites, angioedema, or allergic reactions. Could also be due to low plasma protein levels that is caused by renal disorders, or due to blockage or inadequate removal of lymphatic fluid, or known as lymphedema. So there are two types of edema, the non-pitting and the pitting edema. So pit or depression left during when you press the skin for about 5 to 30 seconds. And then we have to check the scale of edema. So 1 plus or 1 positive if the depression is 2 millimeter, 2 plus or 2 positive if it is 4 millimeter, 3 plus or 3 positive if the depression is 6 mm, and 4 plus if the depression is 8 mm. So moving on to the health history. So as a student, you have to take note of the following common or concerning symptoms, and you must refer this to the physician. If there is pain in the arms or legs, there is intermittent claudication, there is cold or numbness or pallor in the skin, hair loss, or if there is swelling in the calves, legs, or feet, or there is swelling with redness, or there is tenderness, because all of this could be a sign of poor blood circulation. Okay, you may need to ask specific questions of certain individuals that may not recognize some conditions as symptoms, especially those patients over 50 years old or patients with certain risk factors like patients who are smoking, diabetes, hypertension, elevated cholesterol, or coronary artery disease, because they are, again, has higher risk of developing problem with the blood vessels or blood circulation rather. Okay, so you may ask the following question: if there is pain or cramping in the legs. If there is, this could be a symptoms that are caused by insufficient arterial supply to the legs, which may be caused by atherosclerosis. You can also ask if there is coldness, numbness, pallor in the legs, hair on the shin, aching or pain in the lower leg or foot, fatigue or aching with prolonged standing, swelling of the feet or legs if there is swelling, edema, varicose veins, and aching in the legs. Those are all symptoms of venous stasis. You may also check the following: if there is varicose veins, assess if there is non-healing or slow healing wounds, fingertips or toes change color during cold weather, which may be caused by Raynaud disease, wherein the small artery spasms in response to cold. So if there is erectile dysfunction, abdominal pain after eating, tender or swollen lymph nodes, and you can also check your book, table 15.1. Okay, the following are example of chronic insufficiency of arteries and veins. So we have here an image of chronic arterial insufficiency advanced, wherein there is an intermittent claudication progressing to pain at rest, and there is also start of tissue ischemia. So rubor or redness or the ischemic ulcer. So another image of chronic venous insufficiency advanced. Okay, so arterial itong isa, venous naman itong isa. So ulcer often painful. Okay, there is a generalized leg aching, especially at the end of the day. So this can be due to venous stasis and hypertension. So another example of common ulcers of the ankle and the feet, we have here the chronic venous insufficiency ulcer. This condition usually appears over the medial and sometimes the lateral malleolus. The ulcer contains a small painful granulation, tissue, and fibrin. So necrosis or exposed tendons are rare. Okay. So the borders are irregular, flat, or slightly steep. So the pains affect quality of life for about 75% of the patients. So another ulcers. So we have here the arterial insufficiency ulcer, which is the condition that occurs usually in the toes, the feet, or possibly areas of trauma. So the surrounding skin shows no callus or excess pigment. So it may be atrophic. So the pain is often severe unless masked by neuropathy. So the gangrene may occur along with decreased pulses. So there is trophic changes, foot pallor or elevation, and thus pyrrhobore on the dependency area. So another common ulcers of the ankle and feet, we have here the neuropathic ulcer. So in this condition develops in the pressure points of the areas with a diminished sensation. This is usually seen in diabetic neuropathy or those who have neurologic disorders and Hansen disease. So the surrounding skin is callous. There is no pain. So the ulcer may go unnoticed. Kaya napapansin nyo yung ibang diabetic patient, hindi nila napapansin, malaki na pala yung kanilang sugat hanggang sa napuputulan na sila ng paa kasi hindi nila napapansin, hindi nila na-feel na meron na silang sugat or may wound. So these are some peripheral causes of edema. So we have pitting edema. So it is a soft bilateral palpable swelling due to increased interstitial fluid volume and retention of salt and water. So it is demonstrated by pitting on pressure on the anterior tibia and feet. So there is no ulceration or thickening or pigmentation for the pitting edema. On the other hand, we have here a chronic venous stasis or chronic venous insufficiency rather. So it is a type of edema that is soft with pitting on pressure and occasionally bilateral. So you have to look for browny changes and the skin is thickening. So it's unlike the pitting edema. So here there is a skin thickening and then especially near the ankle. So the ulceration, brownish pigmentation, and edema in the feet are common. So this usually arises from chronic obstruction and from incompetent valves in the deep venous system. So another peripheral causes of edema is the lymph edema. It is initially soft and pitting. So una, pitting siya. So makikita mo yung depression. Then becomes indurated, becomes hard and non-pitting. So as you can see in this image, the skin is markedly thickened, ulceration is rare. So there is no pigmentation. So the edema often occurs bilaterally in the feet and the toes. So lymph edema arises from interstitial accumulation of the protein-rich fluid when the lymph channels are infiltrated or obstructed by tumor, fibrosis, or inflammation. So moving on to the past history. So let us now check for the medications, especially oral contraceptives or hormone replacement therapy. So because estrogen use and pregnancy increase one's risks for blood clots. Okay. So that's why you have to check also for pregnancy or recent childbirth. So inflammatory diseases, okay, again, this contributes to clot formation. Active cancer, coronary artery disease, which are also caused by atherosclerosis. So heart attack, congestive heart failure, and stroke. So they are all at risk for peripheral artery disease or PAD. So to continue with the past history, you have also to check for the clotting disorders, hypertension, diabetes, problems in circulation, major surgery, or if the patient has fracture of a long bone in last 4 weeks. Because again, these are all prone to blood vessels a problem or occlusion or insufficiency. So you have to check for the following risk factors. If the patient is, you have to check if the patient is obese or obesity by checking the BMI, smoking, or hyperlipidemia, constrictive clothing, ito ba yung ginagamit, or the central venous lines. Now, moving on to the family history. You have to check if there is a member of a family member from parents, grandparents, okay? So, if merong peripheral vascular disease, varicose veins, abdominal aortic aneurysm, or coronary artery disease, or there is a sudden death younger than 60 years of age, and diabetes. So you have also to check for the lifestyle of the patient. If the job requiring prolonged standing or sitting, okay, na hindi makakapag-circulate ng maayos yung blood, particularly on the lower extremities, or sedentary lifestyle, decreased mobility such as paralysis or cast. Kasi again, poor ang kanilang blood circulation. Now, let's move on to the physical examination. So before you proceed, make sure to check the following. For your equipment, you need tape measure, Doppler ultrasound device, tourniquet, or blood pressure cuff. And you have to position your client to lying down or supine position, and you have to properly drape to allow access to groin area to access femoral artery. So there should be easy access to the arms and the legs. Now for the arm, you have to check or note for the size, if it has symmetry or symmetrical with the other arm. The skin color, is it uniform? Okay. Pwede namang lighter yung unexposed area. Okay, radial pulse, the brachial pulse, and the epitrochlear lymph nodes. You have to check for this. For the legs, you also check for the size, symmetry, skin color, tenderness. Check also for the femoral pulse and the inguinal lymph nodes, popliteal, dorsalis pedis, and the posterior tibial pulses, and also check for peripheral edema. Okay, so to continue with the physical examination of the arms, you have to start from the fingertips to the shoulders. So you can use your cardinal technique of doing the physical examination as your inspection. Okay, you have to inspect for the size, symmetry, swelling, and any lesions. Check for the venous pattern, the color of the skin, and the nail beds. Okay, so the color of the skin should be uniform, no? except for the exposed and the unexposed areas, wherein the unexposed area is lighter than the exposed area. You have also to check for the texture of the skin. So if you notice lymphedema of the arm in the hand, this may follow axillary node dissection and radiation therapy. So for venous pattern, so if there is prominent veins in an edematous arm, this suggests a venous obstruction, such as in those who have deep vein thrombosis. Okay, for the arms, you can also use your cardinal technique known as palpation. So you palpate for the temperature and for the radial pulse. So to palpate for the temperature of the arms and the hands, it should be simultaneous with the back of your fingers, and then you have to compare the temperature of the arm simultaneously. So palpate the radial pulse with the pads of your fingers on the flexor surface of the wrist laterally. By partially flexing the patient's wrist, this may help you to feel this pulse. And you have to compare the pulses in both arms. So pulses may be palpated simultaneously to facilitate comparison. Okay, to continue with the physical examination of the arms, you have to palpate for the brachial pulse. So the following are the recommended grading of the pulses. So to document the pulse amplitude, you have to document it as a fraction with the denominator indicating which scale is being used. For example, here 2 positive over 3, which indicates a normal pulse in this scale. So if you cannot obtain the radial pulse, you have to feel for the brachial pulse by flexing the patient's elbow slightly and then palpate the artery just medial to the biceps tendon at the antecubital crease, as you can see in this picture. The brachial artery can also be felt higher in the arm, in the groove between the biceps and the triceps muscles. Okay, you have to feel for the epitrochlear nodes. With the patient's elbow flexed to about 90 degrees and the forearm supported by your hand, you have to reach around behind the arm and feel in the groove between the biceps and the triceps muscle. So about 3 cm above the medial epicondyle. So if the node is present, note its size, consistency, and tenderness. Okay, so an enlarged epitrochlear node may arise from local or distal infection or may be associated with generalized lymphadenopathy. So now let's proceed to the physical examination of the legs, and we have to use your cardinal technique, which is inspection. So again, you have to inspect for the size, the symmetry, and edema. Okay, measures the leg circumferences. Also check for the venous pattern, enlargement or varicosities, if there is pigmentation, rashes, scars, or ulcers. Color and the texture of the skin and color of the nail beds too. Distribution of the hair on the lower legs, feet, and toes. So again, you have to inspect both legs from the groin and buttocks to the feet. Okay, so to continue with the physical examination of the legs, you have to check or note if there is brownish areas or increased pigmentation near the ankles. This could be due to a chronic venous insufficiency. So check also for the location size, and depth if there is any ulcers that you notice. Okay, so after inspection, you can now proceed to palpation. So you have to palpate for the temperature of both the legs and the feet simultaneously with the back of your hands, and then you have to compare the temperature of the legs. So if there is bilateral coolness, it is maybe due to cold environment or due to anxiety. So palpate also for edema. So compare one foot and the leg with the other, noting for their relative size and the prominence of veins and tendons and bones. So edema causes swelling that may obscure the veins, tendons, and bony prominences. So palpate for pitting edema by pressing firmly but gently with your thumb for at least 5 seconds over the dorsum of each foot, behind each medial malleus, and over the shins. So you have to look for pitting or a depression caused by pressure from your thumb. So normally, pitting edema is not detected. If found, the severity of edema is graded on a 4-point scale, as mentioned in the previous slides. Okay, so palpate also for the thickness of the skin. A thickened, brownish skin suggests lymphedema and advanced venous insufficiency. So palpate areas of local redness, noting the skin temperature, and then gently palpate for the firm cord of a thrombosed vein in the area. So the calf is usually involved, or most often involved. So assess arterial circulation, okay, by checking the femoral pulse. So please take note that if there is local swelling, redness, warmth, and a subcutaneous cord, this suggests superficial thrombophlebitis. Okay, you can also palpate the popliteal pulse by patient's knee should be somewhat flexed with the leg relaxed, and then you can place your fingertips of your both hands so that they meet at the midline behind the knee, and you can press deeply into the popliteal fossa. The popliteal pulse is often more difficult to find than other pulses because it is deeper and it feels more diffuse. So if there is exaggerated or widened popliteal pulse, this suggests an aneurysm of the popliteal area. Okay, now palpate for the dorsalis pedis pulse by palpating the dorsum of the foot, not the ankle, just lateral to the extensor tendon of the great toe. If you cannot feel a pulse, explore the dorsum of the foot more laterally. Also, you can palpate for the posterior tibial pulse. Okay, the dorsalis pedis artery may be congenitally absent or may branch higher in the ankle. So, decreased or absent pedal pulses, assuming a warm environment, with normal femoral and popliteal pulses, this could suggest an occlusive disease in the lower popliteal artery or its branches, usually common in diabetic patients. So, to continue with the palpation of the legs, we have the following tips for feeling difficult pulses. You have to position your body and your examining hand comfortably, and then you place your hand properly and linger there, varying the pressure of your fingers. Do not confuse the patient's pulse with your own. Okay, so let us now move on to the abnormalities of the arterial pulse and pressure waves. So we have here the normal arterial pulse and the pressure wave, and we have here the weak pulse. For the normal pulse, the pressure is approximately 30 to 40 mm per mercury. The pulse contour is smooth and rounded. So the notch on the descending slope of the pulse wave is not palpable. For the weak pulse, the pressure is diminished, okay, and the pulse feels weak and small. The upstroke may feel slowed and the peak prolonged. Yan. So the common causes include a decreased stroke volume, as in heart failure, kaya merong weak pulse. So, hypovolemia and severe aortic stenosis. Also, in patient with increased peripheral resist. So, another abnormalities of the arterial pulse and pressure waves, we have here the bounding pulse. The pulse pressure is increased, ayan, mataas, and the pulse feels strong and bounding. The rise and fall may feel rapid, and the peak is brief. Okay. The usual causes include stroke, increase in stroke volume, decreased peripheral resistance or BOST, as in those who have fever, anemia, hyperthyroidism, aortic regurgitation, and etc. And we have here another abnormalities of the arterial pulse. We have here the bisperience, wherein the pulse, there is an increased arterial pulse with a double systolic peak. Ayan, dalawa. Causes include pure aortic regurgitation and aortic stenosis with regurgitation. So we have here another abnormalities of the arterial pulses and pressure waves. We have the pulsus alternans, wherein the pulse alternates in amplitude from beat to beat even though the rhythm is regular. So when the difference between stronger and the weaker pulse or the weaker beats is slight, it can be detected only by sphygmomanometer. So pulsus alternans indicates left ventricular failure and is usually accompanied by left-sided S3. So another is bigeminal pulse. So this disorder of rhythm may mimic pulsus alternans. So halos kapareho siya. It is caused by a normal beat alternating with a premature contraction. Okay, so another abnormality of the arterial pulse and pressure waves, we have here the paradoxical pulse. So a palpable decrease in the pulse's amplitude with quiet inspiration. So a blood pressure cuff may be needed to detect the difference in amplitude. Usually, the systolic pressure decreases by more than 10 mm per mercury during inspiration. So a paradoxical pulse is found in pericardial tamponade, constrictive pericarditis, and obstructive lung disease. Okay, to continue with our physical examination of the legs. Okay, palpation. Okay, you can palpate for the superficial inguinal nodes, including both of the horizontal and the vertical groups. You have to note for their size, consistency, and discreteness. You also note if there is tenderness or non-tender. Okay, so at the end, you can ask the patient to stand to inspect the saphenous system for varicosities. So varicose veins are dilated and tortuous. Their walls may feel somewhat thickened. Many varicose veins can be seen in the leg in the picture here. Okay, so in recording your findings, you have to take note for the lymph nodes. This was covered in chapter 10, the carotid pulse, and the peripheral vascular system. So these are your baseline in documenting, no? For example, of your documentation, extremities are warm and without edema. No varicosities or stasis changes. Calves are supple and non-tender. No femoral or abdominal bruits, brachial, radial, femoral, popliteal, dorsalis pedis, and posterior tibial are 2 positive and symmetric. So those are example of your documentation. Okay, so let's proceed to the special techniques in evaluating the arterial supply to the hand. Okay, so again, to assess for the arterial insufficiency in the arm or the hand, you can try to palpate the ulnar pulse as well as the radial and the brachial pulse. You can press deeply on the flexor surface of the medial wrist and partially flexing the patient's wrist. This may help you. So the pulse of a normal ulnar artery, however, may not be palpable. So arterial occlusive disease is much less in the arms than in the legs. So absent or diminished pulses at the wrist occur in acute embolic occlusion and in those who have Berger's disease or those who have thromboangiitis obliterans. So to further evaluate the arterial supply to the hand, you can also use Allen test. So this is to compare the patency of the ulnar and the radial arteries. It is also to ensure the patency of the ulnar artery before puncturing the radial artery for blood samples or arterial lines. So the patients should rest with hands in the lap and then the palms up. Okay, as you can see in the picture, you can ask the patient to close, okay, the hand, and then you have to occlude both the the ulnar and the radial artery, and then you can ask the client to open the hand, and then you can remove your hand that occlude the ulnar artery, okay, and then if it is patent, if there is no occlusion, of course you can see that the hands turns red. Ibig sabihin there is blood flow. So on the other hand, if there is a problem with the ulnar artery, okay, as you can see, white pa rin or pallor pa rin yung kanyang hands. So after evaluating the arms, now let us proceed to evaluating the arterial supply to the legs. If there is pain or diminished pulses, this could suggest arterial insufficiency. So you have to look for postural color changes. How to do this? You can ask the patient to lie down and then raise both legs so to about 60 degrees until maximal pallor of the feet develops hanggang mamutla siya, usually within a minute. And then you have to ask the patient to flex the ankle up and down to drain the venous blood. Usually in light-skinned persons, either maintenance of normal color as seen in the right foot or slight pallor in normal. For the dark-skinned persons, you have to evaluate the sole of the feet or the nail beds to check for pallor. So if there is marked pallor on elevation, this suggests arterial insufficiency. Then you can ask the patient to sit up and dangle the legs over the side of the examination table or the bed. And then you can compare both feet, noting for the time required. no? Kung kailan magkaroon ng return of pinkness to the skin. So, ang return of pinkness to the skin normally occurs about 10 seconds or less. Feeling of the veins of the feet and the ankles normally about 15 seconds. Okay, as you can see in the right foot, it has a normal color and the veins on the foot have failed. So these normal responses suggest an adequate circulation. On the other hand, the patient's left foot is still pale and the veins just starting to fill. This could be a sign of arterial insufficiency. If the patient has higher risk or has factors for peripheral artery disease, so an ankle brachial index screening should be performed. This is a non-invasive method to assess the lower extremity arterial blood flow, wherein you have to compare the systolic blood pressure in the ankle to the arm. So the following equipment are needed to perform ankle brachial index. You need Doppler device and gel, blood pressure cuff from arm and leg, and then you can proceed to your book, or you can check your book on page 461 for the procedure. Okay, for the procedure of the ankle brachial index, make sure that the patient has no caffeine, tobacco, or heavy activity for at least 1 hour prior to the procedure. You can ask the patient to empty the bladder and remove tight clothing, shoes, and socks. So you can use Doppler to obtain the arm arterial systolic pressure in both arms. And you can use Doppler to obtain leg arterial systolic pressure. So you have to put the cuff just above the malleoli in both legs. So for the calculation, you have to divide the higher systolic pressure from each leg by the higher brachial systolic pressure. So this is an example interpretation. So if it is greater than 1.3, it is unreliable. So the normal is 1. Okay, to evaluate the competency of the venous valves, you can do this by checking the retrograde filling or the Trendelenburg test, or through pulsus alternans, or by paradoxical pulse. Now let's proceed to health promotion and counseling, which is part of your nursing care plan. Okay, so the following are the important topics that you must include. Okay, for the arterial disease, you can teach the following topics to your client: smoking cessation, weight control, exercise program, hypertension control, hyperlipidemia control, diabetes management, limiting alcohol intake, and foot care. On the other hand, for the venous disease, important topics that you need to include are the following: avoidance of prolonged sitting and standing, avoidance of constrictive clothing, including girdles and tight hose. You can also include exercise program, weight control, food care, dehydration prevention. That ends our presentation, that ends our physical examination on the peripheral and lymphatic system. And these are the references. Okay, to end this presentation, let me share to you this verse from Luke chapter 1, verse 37. For with God, nothing shall be impossible. Thank you everyone, and God bless.